Thank you so much, Susanna, and thank you so much, Zomerica, for this great opportunity to present again. So I'm really excited to talk to you about the HPA axis function today and cortisol regulation in sick horses and foals. So this is the outline for the lecture. So we'll focus mostly on the hypothalamic pituitary adrenal axis physiology and cortisol regulation. I will also talk about physiological and immunomodulatory effects of cortisol. And then we'll move on into alterations in cortisol, and that includes hypoadrenocorticism. Mostly in horses, we talk about relative adrenal insufficiency, as well as hyperadrenocorticism, which is also not it's not that common in horses. A number of studies have shown that in critically ill people, but also in critically ill foals, there is a dysregulation of several endocrinological systems. And that includes the thyroid, pancreas, and other systems. So the most important endocrine system in response to stress associated with sepsis and critical illness in general is the hypothalamic pituitary adrenal axis that is activated during stress to modulate metabolic activities and inflammation. And it's also important for neonatal foals for organ maturation. Now, going over physiology of the hypothalamic pituitary adrenal axis, in response to stress, the hypothalamus releases a CRH, which is a corticotropin-releasing hormone, and arginine vasopressin. And these two hormones then stimulate the pituitary gland to produce ACTH, or adrenocorticotropin. ACTH then acts on the adrenal cortex to induce synthesis and release of cortisol, which is glucocorticoid and the main stress hormone, but it also produces other steroids, aldosterone and steroid precursors, and sex steroids. So this is adrenal cortex, and the adrenal cortex can be divided into 3 layers of tissue based on the cell type and function. And here on the top, so the outermost is zona glomerulosa, so that's where aldosterone is produced, which is the main mineralocorticoid. And then here in the middle, we have zona fasciculata. So this is the part that we are interested because that's where the cortisol is synthesized and released. And then the last one is zona reticularis, so that's where sex steroids are produced. Steroidogenesis, it is a biochemical process by which steroids are produced from the cholesterol, and it's a very complex, as you can see, very complex process. There is a lot of pathways and a lot of precursors. But what is important here is that cholesterol is converted to pregnenolone, and pregnenolone is a common precursor for all of the steroids. And that includes cortisol, which is glucocorticoid, and aldosterone, which is mineralocorticoid. So what are the key cell and tissue effects of cortisol? So these can fit into sort of 3 categories. So the first one is maintenance of blood pressure. The second one, provision of energy to tissues. And the last one is the control of appropriate inflammatory response, as well as maturation of organs in neonatal animals or neonatal foals. Cortisol regulates blood pressure through increasing sensitivity and production of catecholamines. It also decreases the production of vasodilators such as nitric oxide. Glucocorticoids are also catabolic hormones. So they are vital for increasing blood glucose, and that is by increasing gluconeogenesis, but also inhibiting insulin and liberating stored energy by increasing lipolysis as well as protein catabolism. And then lastly, cortisol plays a key role in modulating the maturation and function of other endocrine systems in foals, and that includes thyroid gland, that includes pancreas and growth hormone systems, and also other organs. So it's very important in the lung maturation and pulmonary surfactant synthesis in fetus. Glucocorticoids have been used clinically for decades as an anti-inflammatory and immunosuppressive agents. Glucocorticoids, like other steroids, diffuse through the cell membrane, and they can bind to the cytoplasmic glucocorticoid receptor, GR. Upon binding to cortisol, the GR, or glucocorticoid receptor, undergoes a conformational change that allows it to dissociate from the heat shock protein, and it translocates into the nucleus, the cell nucleus. And there it binds to the glucocorticoid response elements to activate or repress gene expression of various inflammatory cytokines and other proteins. There are also some other effects that the glucocorticoids and cortisol play in modulating inflammation and immunosuppressant. And those are probably the most important when we talk about sepsis, is the modulation of the inflammation. So they work through a number of cellular mechanisms to produce these anti-inflammatory effects. And that includes suppression of the arachidonic acid cascade through inhibition of two enzymes, phospholipase A2, as well as cyclooxygenase. And this results in decreased production of several classes of inflammatory mediators, including leukotrienes and prostaglandins. And there are some other immunomodulatory and anti-inflammatory effects that cortisol induce, and that includes alteration in gene transcription of inflammatory cytokines, both pro-inflammatory and anti-inflammatory cytokines. Cortisol also decreases neutrophil migration into tissues, and it also suppresses lymphocyte proliferation and function. Okay. As I already mentioned, glucocorticoids or cortisol, like all the other steroids, they are lipid soluble, and they can easily cross cell membrane. So cortisol cannot be stored in the adrenocortical cells, but rather is secreted into systemic circulation immediately after ACTH-induced synthesis. Therefore, most of the steroids, including cortisol, are bound to the protein. So 90% of cortisol is bound to the cortisol-binding globulin, and only free unbound cortisol is biologically active. There is also growing evidence that the complex of CBG, cortisol-binding globulin, and cortisol may have a direct effect through cell surface receptor that has not been described yet. And there are some studies looking at free unbound cortisol or active cortisol and its effect on the diagnosis of adrenal insufficiency. However, it doesn't seem like in horses there was any benefit of measuring free cortisol. Okay, so now I'm going to move into alterations in cortisol. So we have two forms, hypoadrenocorticism and hyperadrenocorticism. That's been described in general in horses and other animals. So interestingly, there are some species differences. So in horses, the permanent adrenocortical insufficiency, also known as Addison disease, it's not very well described. It's very rare. There are some case reports of suspected Addison's disease, but it's really not a disease that we commonly see. transient relative adrenal insufficiency or critical illness-related corticosteroid insufficiency has been reported and described pretty well in critically ill people, but also critically ill septic falls. And we'll talk about that a little bit more. And then in terms of hyperadrenocorticism, so one of the forms is PPID, pituitary pars intermedia dysfunction, or equine Cushing's disease. So in some horses with PPID, we also see increased cortisol production, but it's not consistent. And it is important here to mention that PPID, it is not adrenocortical disease. It is pituitary pars intermedia dysfunction. And in those horses, ACTH is consistently increased, but not cortisol. In some of them, but not all of them. So now I'm going to move into relative adrenal insufficiency, so also known as critical illness-related corticosteroid insufficiency or CIRSE. So it is defined as a transient impairment of the hypothalamic pituitary adrenal axis dysfunction that occurs during critical illness in people, but also in other species and in foals. And it results in abnormal cortisol production. So usually there is a low cortisol production, abnormal cellular activity of cortisol, as well as altered metabolism of cortisol. So there are several mechanisms that are involved in the HPA axis dysfunction. And it's been shown in people, so critically ill people and other species, as well as in septic falls, that CIRSE is associated with increased mortality as well as severity of disease. Diagnosis of CIRSE is based on low baseline cortisol, so we can measure cortisol. And also we can determine cortisol response to various different stimulation tests, including ACTH, CRH, and vasopressin stimulation test. So now going back to the adrenal cortex. So in horses, adrenal gland is a highly vascular organ, and it's susceptible to hypoxia, thrombosis that often occurs in septic falls. So you can see here, those are examples of hemorrhagic adrenalitis in falls with sepsis. As you can see on this example here on the bottom of that picture, so this adrenal cortex, you can see severe hemorrhage. And you can imagine that when the adrenal gland looks like that, it's probably not going to make a lot of cortisol. Due to the broad spectrum of abnormalities that may cause CIRSE, and that includes dysregulation of the HPA axis at any of the levels, alteration in cortisol metabolism, as well as tissue resistance to glucocorticoids, it is unlikely that a single test can reliably diagnose CIRSE independent of its mechanism. The HPA axis dysfunction, it is a very complex. It involves a lot of different mechanisms, and it is challenging to diagnose. And it's important to remember that the interpretation in the light of the clinical status is the most important. And until we have a point of care tests that are available and for cortisol and ACTH, which looks like we might have an options now, then sometimes, the only thing that we have as a clinical picture that is available quickly to make a presumptive diagnosis of CIRSE. And then decide whether we have to intervene and provide some treatment for that. So some of the diagnostic approaches that have been described for CIRSE and used in critically ill people as well as in septic falls were measurements of baseline cortisol, so baseline glucocorticoid. Sometimes it is difficult or hard to interpret just a one-time point measurement of cortisol because a lot of factors can affect cortisol concentration. And that could be stress, that could be critical illness, inflammation, etc. Some other approaches are ACTH cortisol ratio. When you have a high ACTH and low ratio and low cortisol, that's gonna increase our ratio, which again is consistent with adrenal insufficiency. And then lastly, dynamic testing. Dynamic testing is more sensitive. And there are various different tests that Ben described. So probably the most common used one is ACTH stimulation, but there are some others recently described, CRH and vasopressin stimulation test as well. And we'll talk about that in a minute. So starting with ACTH stimulation test. So this is the test that's been described probably now 15, almost maybe 20 years ago in healthy and as well as sick foals. And this test assesses the adrenocortical function and cortisol response. For ACTH stimulation test, we can use 2 doses, so either 10 micrograms or 100 micrograms IV. And the protocol is we take a baseline sample for the baseline measurement of cortisol, then we administer ACTH IV, and we take another sample 30 minutes later. In healthy foals, we would expect that cortisol increases at least 1 to 2 folds from baseline 30 minutes after ACTH administration. However, in critically ill foals, the cortisol response may be lower, right? So it will be less than 1 to 2 folds, and that is associated with or consistent with CRC or relative adrenal insufficiency. And based on this data, we propose an algorithm for the management of foals with suspected CRC, and it's been published in this equine neonatal medicine textbook last year. And that's mostly based on data from Dr. Kelsey Hart's studies. So when we have a foal with clinical suspicion of adrenal insufficiency, and this foal has also clinical evidence of septic shock, so it's hypodynamically unstable, then we don't necessarily have to do any diagnostics. We can administer or we can start hydrocortisone therapy in a very sick foal like that. However, if the foal is otherwise hemodynamically stable, but has persistent hypoglycemia or high lactate after fluid therapy, has evidence of SIRS, fevers, then we can measure baseline cortisol. And then in terms of the normal ranges for cortisol, we know we have some data what the normal baseline cortisol should be based on the age of the foal. So here on the bottom, we have normal ranges for the healthy foals, depending on the age. And the very young foals after birth, they have high cortisol, and the cortisol concentration decrease over time, all the way till they are 5 to 7 days old. If that baseline cortisol is normal, then we can do ACTH stimulation using 10 or 100 microgram, as I've already discussed before, and look at the cortisol response 30 minutes or 90 minutes if we are using the higher dose of ACTH. And again, in healthy foals, we would expect that this cortisol is going to double from baseline, or it's going to increase 3 to 4 times if we use the higher dose of ACTH. And if that cortisol response is decreased, then again, this suggests relative adrenal insufficiency, and we can treat this foal with hydrocortisol. There are different assays for cortisol as for other hormones, as I'm sure you know. And most of the labs use either Imulite 2000 or radioimmunoassays, and cortisol measurements or analysis is available through most of the diagnostics lab at Michigan State University, Cornell University, but also IDEX and Tech. And we have to remember to use laboratory references, right? Because again, it may be different depending on the methods that is used for cortisol measurement. And then now, most recently, we are very excited because TruePharma now recently offers cortisol assay for horses as well, which is very important when we treat critically ill foals or critically ill horses, because in this case, we can get the results in 15-20 minutes, and we can immediately start the treatment. And again, this is essential and critical for those very sick animals, because we cannot wait for the cortisol results, right, to come back in 1 or 2 days. And here on the top, so this is the correlation between cortisol that was measured with radioimmunoassay and true forma, and you can see, this is a very good correlation that's based on very small pilot data, but the correlation looks really good. ACTH stimulation test has some limitations. And so unfortunately, it produces inconsistent results. So there's a lot of individual variability in cortisol response. And that's true for healthy as well as sick animals, and similar findings were described in people. The other important limitation is, as I already mentioned, is that ACTH stimulation only assess adrenocortical component of the HPA axis. So if there is a dysfunction at the pituitary level or at the hypothalamus, then those faults may be misclassified. Therefore, the question that we asked was, is there a better test, or is there another test that we can use to assess the function of the entire HPA axis? And recently, we published a couple of papers. So one looking at corticotropin-releasing hormone stimulation test in healthy and hospitalized foals. And currently, we are working on vasopressin stimulation test. And the first part of the study has been published 2 years ago, looking at vasopressin stimulation test in healthy foals. And the goal of the study was to determine the optimal dose of vasopressin. So the overall idea is to, when we administer exogenous vasopressin or ovine CRH in a normal healthy foal, we would see an significant increase in ACTH and cortisol. And this is how it looks like when we make a graph. So here we have a baseline cortisol. In 2 groups of foals, we have healthy foals. So that's the blue squares, and then the black circles, those are hospitalized foals. So you can see that there is a significant increase in cortisol concentration 30 minutes after, in this case, that was a vasopressin stimulation. And that increase in cortisol in hospitalized foals is lower. Conversely, when we have a sick foal or septic foal or critically ill horse, when we administer vasopressin and CRH, the response of ACTH and cortisol will be significantly decreased or will be lower. And this is an example of the foal with adrenal insufficiency. So we can see, so this is the baseline cortisol, and this is cortisol after vasopressin stimulation, 30 minutes after vasopressin stimulation. And as you can see here, there's no change in cortisol. So there is no response of cortisol to vasopressin stimulation, which again, it is consistent with the HPA axis dysfunction. Based on this data, we proposed a protocol for the hypothalamic pituitary adrenal axis assessment in critically ill foals using either vasopressin, so 5 international units, or ovine CRH, which is 1 microgram per kilogram. So after baseline sample collection, we administer vasopressin or CRH and then collect sample 15 minutes at 15 minutes for ACTH response. And then the second blood sample is collected at 30 minutes for cortisol response assessment. And if you are going to ACVIM forum this year, Dr. Mariah Albrecht, she will be presenting the hypothalamic pituitary adrenal gland axis response to vasopressin stimulation in critically ill falls. So if you're interested and you would like to learn more about it, please stop by. Okay. So now, once we have a diagnosis of adrenal insufficiency, then the treatment is hormone replacement therapy with hydrocortisol. The dose is 1 to 3 milligrams per kilogram per day. So that's the total dose. That is split it into multiple doses every 4 to 6 hours. So idea is that, you know, we this is 1 to 4 times the main daily endogenous cortisol concentration. So it is important to remember that the goal of treatment for CIRSE is physiologic cortisol replacement, because it's been shown in a number of studies in people that if we use a higher dose, superphysiological dose, then it may actually decrease survival, and it has an effect on the severity of disease and can cause some significant complications. So it is also probably more beneficial to use less potent and not longer acting steroids. That's why we choose hydrocortisol over dexamethasone or prednisolone. Okay, so now I would like to go over a case. So this is an example of a fall with adrenocortical dysfunction. So this was a 5-hour-old Cortisol filly, which was presented to us because she was weak, unable to stand. She was not nursing. She was not following the mare. She was a full-term fall. It was a full-term fall, but the falling was unobserved, and the mare had evidence of placentitis or suspected placentitis. So when the filly came to us, she was down. She was unable to stand. Her heart rate was 60, which was lower than we would expect. She had a respiratory rate of 44, and she was hypothermic. So her temperature was 97.5. And she was unresponsive. And this is her blood work. So this is the venous blood gas. So as you can see, she had a very low pH, 7.009. She also had a number of electrolyte abnormalities, right? So low sodium, hyponatremia, hypochloremia, hyperkalemia, and severe hypoglycemia. So very low blood glucose and significantly increased lactate of 16.8. So based on the clinical signs as well as blood work, we suspected that she could have adrenal insufficiency. And we were able to measure baseline cortisol and baseline ACTH with Truforma. So these are the numbers that we got. So baseline cortisol was 2.8 micrograms per deciliter, and ACTH was 16.5. So in terms of interpretation, so we used cortisol, normal cortisol ranges for healthy fall. And we would expect that a 5-hour-old fall should have cortisol anywhere between 6.7 to 13 micrograms per deciliter, and certainly 2.8 micrograms per deciliter in face of critical illness and severe hypoglycemia and hypotension. So that was lower than we would expect and consistent with adrenal insufficiency. Now, ACTH concentration is a little bit more tricky to interpret. So her baseline ACTH was 16.5 picograms per ml. And then looking at published studies in septic falls, so most septic falls will have a median ACTH anywhere between 140 to 180 picograms per ml. So again, 16.5 in a very sick falls, it's again lower than we would expect. So again, this is consistent with pituitary gland dysfunction. So the treatment for sepsis was, somewhat that the treatment was similar that we do for other falls, septic falls. So she's had antimicrobials, IV fluids, she had plasma, a lot of supportive care, enteral parenteral nutrition. But we also started her on hydrocortisol, 3 milligrams per kilogram per day, and that was split into multiple doses. So she got about 25 milligrams IV every 4 hours. And she recovered, so she fully recovered. She went home 8 days later without any complications. So it was a very good case of a sick fall that went home. Okay, so now I'm gonna finish up this talk with just talking a little bit about endocrinopathies in horses. So, any critical illness, emergency, and a trauma. So this is an example of severe head trauma in a horse. So all those conditions, they may result or they may be complicated with adrenal insufficiency also, or other endocrinopathies as well. And then some other examples include colic or severe colic or colitis, right? Endotoxemia. So this all may result in the hypothalamic pituitary adrenal axis dysfunction, as well as pneumonia, severe pleural pneumonia. And here we also have an example of a horse with pulmonary edema. So again, all those horses, they may already have adrenocortical dysfunction, or they may develop cortisol insufficiency during the course of the illness. So we don't really know a lot about CIRSE in horses. There are very few studies. But we know Dr. Stewart and her group, they published paper looking at the low dose of ACTH stimulation in healthy adult horses, and they found that the dose 0.1 microgram per kilogram resulted in a maximum adrenal stimulation with a peak cortisol that occurred 30 minutes after ACTH administration, similarly to Foals, and the peak concentration was almost 2 times from the baseline concentration. And in the same group, they look at ACTH and cortisol concentration in horses with systemic inflammatory response syndrome. And they found that horses that did not survive, and as well as horses with ischemic lesions, they had higher concentration of cortisol and ACTH cortisol ratio. So the overall conclusion from the study was that pituitary and adrenal responses are altered in non-surviving horses and those with an ischemic gastrointestinal lesions. And now, so more recently, so this paper was published looking at the effects of ascorbic acid, so vitamin C, and low dose of hydrocortisone in horses that had an infusion of LPS lipopolysaccharide. So authors also used ACTH stimulation test to assess the HPA function. So the dose that they used was 0.1 microgram per kilogram, and they found that the horses that got LPS had evidence of CIRSE, and the cortisol response was much lower compared to the control group, right? So compared to healthy horses. So healthy horses had a cortisol increase by almost 6 micrograms per deciliter, and then horses in the study, so the one that had LPS, increased by half of that, so 2.6 micrograms. So that all, tells us that, ACTH should be a good test. It is a good test to determine whether the horse has adrenal insufficiency. All right, so just to summarize, so the take-home message from this lecture is that CIRSE, or relative adrenal insufficiency, as an important complication of sepsis, as well as endotoxemia in foals and horses. And it is associated with increased mortality and severity of disease, and may be important to diagnose, right? Because that can improve the outcome in foals and horses. And diagnosis of CIRSE is challenging. So we have some options, and now we have some assays available, point-of-care assays available, which are critical for the timely diagnosis and management of those very sick foals and horses. We can look at baseline cortisol and baseline ACTH concentration, as well as dynamic tests, and hopefully we'll get some more information on vasopressin stimulation tests soon. And then finally, the hormonal replacement therapy with hydrocortisone is recommended in horses or foals with suspected CIRSE, and it may improve their survival in those animals. All right, so that's all I have about cortisol and the HPA axis dysfunction in critical illness. We'll be happy to take any questions. Also, feel free, if you want, you can email me if you come up with any questions later.